Thank you, Malin and Vinova, for this kind invitation and for all of you being present in the room today and online. So it's my distinct pleasure to represent Region Halland here today and remind you a little bit about what can be done with data and healthcare data coming from within. And this is not always new technology, rather than a way of putting forward a new way of organizing and working together. So I work as a strategist in the FoU in Region Halland, and my designated area is implementation. Although, as all of you are aware, there are many parts of implementation leading forward to the decision of actually adopting a new technology or way of working. My background is at Lund University. I'm a researcher by training and have an associate professorship in molecular medicine there. And so it's a big joy for me to take part in today's meeting and also hear the other presentations to where the fields has developed in the last years. And I was also thrilled to take part because I was also pleasured to be in Valencia last year. And so this has been a good starting point for me. But moving forward, so you have heard already from Anna and others about the regions in Sweden. So healthcare governance in Sweden is governed by a single government responsible for the overall healthcare policy and the legislation and the grants, but also the activities of the government agencies. The regions, 21 in number, are responsible for provisions, and they meet the legislative requirements, of course, but they are self-governing local authorities, governed by a political regional assembly, and they do this with taxpayer money and have responsibility for the population. So Region Halland, in the red circle, is located on the southern west coast of Sweden. 340,000 inhabitants, 3 hospitals. None of them are a university hospital. So we have long and well-functioning collaborations with Sahlgrenska in Gothenburg and the hospital in Lund for these types of analysis and diagnosis. Looking at medicine today and precision medicine, it's really an evolvement. And many have already touched upon this today, and you are well aware. But medicine as is evolving as we learn more about the population and the groups. We're able to stratify. We're able to notice who will have side effects of medications or who will not respond well to different treatments. This is in fact precision medicine. And looking forward into the future, I think we will reach even further if we are able to take the technological advancements and organizational advancements into the population and apply this also in people, as someone put it before, to actually achieve preventive medicine and preventive health. And as we move along this spectrum, the data volumes and the complexity of data has evolved. This was not the case 50 years ago, where we did not have data in the same way as we do today. And so this is true in many places, but what's unique about Region Halland is that a few years ago, the data systems were all gathered together in one common data warehouse. This means EHR, this means lab data, this means HR and financial data, all put together. I think in total, something like 600 systems converged. And this data was then mirrored into a production area, and it was possible to withdraw data, analyze, and look at to learn more about the internal organization and the way to proceed with healthcare and other processes. And so this has given rise to a term called information-driven care. This is not a topic in itself. It is in fact a systems approach to healthcare, looking at production, the clinical setting, the patients, of course, the providers in forms of staff and capacity, and of course, what also comes along is the cost. And because Region Halland has done this in a functioning way, a lot of research goes on premises, even though it's not a university hospital. And we are also very attractive to external research proposals coming from, for instance, the pharmaceutical industry. So, looking forward about precision medicine, care must be precise. Well, what do we mean by that? Of course, we mean that the right care should be given to the relevant patient at the right time. We also believe that it should be predictive. Prediction of clinical needs, including staffing and organization, and also the pre-symptomatic detection of disease, or early detection, as it's sometimes called. I'm going to show you a few examples now of how Region Halland has worked with their data to achieve some key insights and findings. And this is the first. So, looking into the entire population and searching through creatinine measurements, looking at CKD, chronic kidney disease, it was found that over 20,000 patients met the criteria for chronic kidney disease, and twice the amount were identified as being at risk for this state. But only 18% had actually received the official diagnosis, and another number, 65%, were, however, followed annually. And looking into if they were treated properly for this with drugs, only 34% had statin prescriptions, and 43% had relevant inhibitors on board. And so this kind of reveals something about healthcare and the population, that perhaps it isn't as we imagine. Perhaps it is in a different way. And perhaps you need to reorganize and put other measures in place if CKD is in fact underdiagnosed, undermonitored, and undertreated. It also puts another topic at the surface, and that is that medicine as is sometimes has not evolved. It is not dynamic. The reference values could also need tending to, and the question arises if guideline adherence in other areas also are faulty or can be improved. So if you have your data in order, you can also analyze reasons for patients visiting the emergency department. And this can lead onwards to research in trying to differentiate between the three major causes of why patients end up in the emergency care presenting with shortness of breath. So this can, in the future, the model that was developed here was put forward and able to provide some guidance for clinicians in the emergency department to what symptoms to look for with people who present in the emergency department. And this study is one of many, but it does point out that it has looked at the complete regional population and the entire regional healthcare system data, which reduces also the risk for selection bias. And in another area, quite interesting and important, enabling precision prevention and early detection in the field of mental health. So this was a short study done looking into the risk of individuals receiving an ICD-10 code in the category F. And it was found that it was actually possible to detect the risk of a diagnosis of anxiety or depression 12 months prior to it actually occurring. Again, if we can act early, we can put measures in place that sort things out, both for the healthcare system and for the patient. Here's another example of readmission of patients with congestive heart failure, putting all the variables in place and comparing two different AI models, explainable in two different ways, and looking at what actually puts patients at risk for readmission. Again, the more you know, the more you can do for these patients before they become readmitted to hospital. And life and suffering are spared and costs are also reduced. And to the right in this image, you can see what we call a dashboard. Dashboards are frequently developed in the clinical setting based on the data. It all draws from that first warehouse cylinder I showed you in the early picture. So there's one common source of data but it can be put to many different uses throughout the hospital and throughout different professionals and professional settings. Yes, so care must be precise and predictive. It should also be person-centered and unfragmented. Looking into the different types of care, and this is borrowed from Leading Healthcare. If you look at figure 1, or field number 1, this is something very simple. Perhaps you broke your arm, you go to the hospital and you receive help for this, and then you go home. That's the end of that care trajectory. However, if you receive a cancer diagnosis, you might enter into our famous SVFs, the care trajectory, care pathways. And you're taken through the system in a limited amount of time, and you receive standardized care, and hopefully you are cured and can go home. In the third situation, this is where chronic and complex conditions end up. Much like our patient representative spoke about earlier, you have recurrent situations, visits with your care provider, and you're taken care of, you're monitored, you're living with chronic cancer, perhaps, or this is also common in the ophthalmology field. Well, however, in field number 4, we have the really problematic cases which incur a lot of costs and a lot of suffering for the patients. It usually involves lack of diagnoses. The silos that we've heard about earlier today are really not working in favor of the patient or society. And this is where we believe a lot of efforts should be put and a lot of value can be created going forward. Another thing to be aware of is that the type of provisions of care, so we spoke about regions. There are also something like 291 municipalities in Sweden, and these are responsible for another type of care, typically the elderly homes and other kinds of care homes in this way. And if you look at data, these are separated, so you cannot view an entire care chain from region to municipality and back from the point of a researcher or from a caregiver. Also, the caregivers are prohibited from viewing each other's medical charts. And there are also different traditions in the ways that the disease is reported and measures are reported. And this creates even further siloification and problems when it comes to interpreting where we are and what we should be doing for the population. And this is another image basically showing the same thing. If you drop your keys, you're more likely to look where the light is. And we all have our own flashlights as experts. And so we look at the world like this. Well, it's important to come together and have one single light, one common source of data to achieve one common source of knowledge and one information base. So having taken these steps, as we have done in Region Halland, novel insights have been made, and they have provided a new base for incentives and decision-making. Well, what do I mean by that? Well, looking into the impact on climate that different diagnoses can have, it was found that the different chronic kidney disease stages, in fact, influenced climate impact differently. And so what was thought initially was that it was the transportation of patients being brought to the hospital that was the major part of this CO2 equivalence. But in fact, it was hemodialysis. So again, these values of climate and health converge here. If we can do anything to stop patients from ending up in hemodialysis, it will be a gain not only for the patient, but also for the climate. Again, looking across the healthcare system in Halland, there are many different dashboards which monitor many different areas. And this is not AI. This is in fact sometimes very simple data, but it's very much used by different professions throughout the day And it's sometimes updated as often as every 15 minutes, which means the physicians don't have to call around looking for a hospital bed. They can go to the dashboard and they will know. I just brought this up as an example from COVID because it's some experiences that we all share in different ways. In the green bars, you can see a number of patients with positive COVID tests in the hospital per day. And you can also view the ICU occupancy rate at the 2 different ED hospitals in Halland. So I guess the key messages, we have arrived at this slide. A data-driven systems approach uses the data from within to aid in understanding and enabling precision medicine, and this in itself motivates investment. Precision is arriving at the conclusion of relevant treatments and diagnostics, and this includes screening, early detection, and resource utilization. The data-driven approach should be, we believe, patient-centric rather than organization-centric, although actions are planned and costs are reduced, staffing monitored, and preventive measures possible. And again, as many others today have pointed out, we fully agree that success requires collaboration across knowledge domains. We are also in favor of recruiting from different sectors to create this dynamic environment. And going forward, data infrastructure and access is a very important issue. International standards must be deployed broadly or interoperability achieved by other means. We believe in maintained research investments, but while still promoting incentives towards adequate and precise solutions to real-world challenges, including prevention. Funding must allow for long-term multi-party efforts with ties to activators of the track of research, innovation, implementation. And you'll notice I also added commercialization here. It's important, we think, to promote accountability, counteracting off-my-desk mentality, or this is as far as my interests go. We all need to work more towards the holistic approach to make sure that things we do actually reach practice. We also believe in identifying and strengthening funding mechanisms, or reimbursement systems, if you will, that allow the benefits to occur elsewhere in the system or society. So, thank you very much for your attention. I hope you found some of this interesting. We had a visit earlier this year by the National Board of Health and Welfare, and they brought along their friends from the WHO. And so they were interested in information-driven care and how that translated into workforce and staffing issues of the future in healthcare. And you can read more about this on our website, and I'm happy to take questions if there's time.
Thank you, Helena.